So, good evening, everybody. Hello and welcome to this edition of Ask Your Doctor. I'm Dr. Alan Thornhill. I've been working in the field of IVF for over 25 years in a variety of different roles, starting as a clinical embryologist in the lab, then moving into industry, actually involved in some of the tests we might talk about tonight, and now providing support and guidance for patients as a fertility coach. This evening, I'll be your host for what's going to be a fascinating session. Many people working in IVF have spent a great deal of time and effort researching the embryo and not so much the endometrium or lining of the womb where the embryo implants. In the past 15 years or so, there's been a great deal of research into implantation, and rightly so. If you think of the embryo as the seed and the endometrium as the soil, it's clear that to grow a healthy plant, or in this case a healthy pregnancy, you need both a good seed, healthy embryo, and good soil, healthy and receptive endometrium. I'm joined tonight by a fantastic set of panelists who are here to help you better understand what is the implantation window in fertility treatment and how to improve it. They are Dr. Evangelos Papanikolaou, reproductive medicine specialist and co-founder of Assisting Nature Clinic in Greece, Dr. Susanna Malkhasian, gynaecologist and fertility specialist at Vistahermosa in Spain, and Dr. Halyna Strelko, co-founder and leading reproductive specialist at IVMED Fertility Center in Ukraine. And we're going to start by asking each of our panelists to give a brief introduction to the topic, and then we'll answer your questions. And that's because I want to make sure we have a background understanding before we get into the details. If I can ask you please to put your questions in the Q&A box, not the chat, that will help us to deal with all of them. We'll try to answer them all, but I'll prioritize ones that are easy to generalize, haven't already been answered, because sometimes people ask the same question a bit later, and ones that stick to the topic, because it's quite easy to start asking different things, just in the interest of time. Okay, so I think we'll start by asking Dr. Evangelos to explain very briefly and very simply what's the window of implantation, why do we know about it, and how can we identify it, and why is it important?
Hello, everybody, and we are very thankful for this kind invitation. The window of implantation is very crucial because it renders the female partner of a couple and of the particular of the humankind not being able to become pregnant in any certain point of the cycle. So it's only a defined period after the ovulation that we can become pregnant, because otherwise, like other animals, we will become pregnant very easily. And this, we don't want it in humankind, because we could become pregnant after violations or after rape. So there is there to protect the women to not becoming pregnant very easily, and only after our willing. So actually, the window of implantation is very difficult to define when exactly is, but as a general idea, after different studies since 1956 in the United States, has been defined that is 5 to 8 days after the ovulation. This is the first point regarding physiology, and the things that we might discuss today is whether there do exist women that they have a different window of implantation, whether doctors iatrogenically with our stimulation alter the window of implantation, or if we can improve the window of implantation with any medication that can be administered in the luteal phase. This is my introduction, please.
Thank you so much. Let me just move on to the next question. Dr. Strelko, could you answer the question, what can we do to assess endometrial receptivity before embryo transfer? So obviously I'm generally, rather than specifics about specific tests, but what are we doing, what methods do we have to look at receptivity in basic terms, please?
Good evening. Thank you for this invitation, for this event. And to answer your question, I would like to start with more old method of implantation window study named Pinapodi study. It was quite old method and concerned to histological study and electronic microscopic study of endometrium and some morphological findings named Pinapodi. Some epithelium structures which was discovered in the time when endometrium was more ready to receive embryo. But approximately 10 years ago, genetic discovered different method to evaluate endometrium receptivity, and now it is more often used this method named ERA test, endometrium receptivity assessment test. Authors of this method study different genes expression in endometrium in different time of progesterone taking, after 5 days of progesterone, after 7 days of progesterone, after 3 days of progesterone, and then discover some genes expression which should be at the time when endometrium is ready to receive embryo and when embryo have the maximal chance to implant in this endometrium. And now this is the more modern and the best way to access endometrium receptivity. So
Thank you.
Like
that's really nice and simple and clear. Could you briefly say how you do the test? You know, what you have to, what a lady has to go through with a doctor to get the test done.
First of all, as for me, it is not the test to do for all women. Normally should be as minimum 1 to unsuccessful transfer with good quality embryo. And this is crucial, because if the quality of embryos is not very good, the first problem is embryo quality. That's why we can thinking about implantation problem only in case when we have very good embryo quality. Then necessary to do the preparation of endometrium like we are thinking to do the transfer. It may be 2 ways of preparation of endometrium. Replacement hormonal therapy, it means artificial hormonal cycle, or it may be what we call natural cycle, or modified natural cycle. And then after 5 days of progesterone in a replacement hormonal therapy cycle, or after 7 days after LH peak or HCG injection, we can take sample from uterus, around 1 millimeter of endometrium tissue, and then we send this sample in genetic laboratory. And genetic laboratory compare this gene expression with what should be in this moment, and then give the answer. Your endometrium at the moment of sample is receptive, pre-receptive, or post-receptive.
Perfect. Very, very nice, very succinct, very clear. So now I'm going to move on to Dr. Malkhasian, and this is kind of, I don't know, this is more of a kind of, we'd probably ask this question right at the end, but I'm going to ask you right now because I think it sort of opens up the thought process. What's more important, the embryo or endometrium quality?
Good evening from Spain. Obviously, it's important. Both of them are very important because we can have a good embryo, good quality embryo with PGTA test before, so we know that it's healthy. But if the endometrium is not prepared, it's not thick enough, or something more happen, have another problem in the endometrium, obviously it would not implant. And the same thing we can say about the endometrium. We can do the best preparation and everything, the hormone levels, check all the things that we can check and have the perfect endometrium to receive the embryo. But if the embryo is not so good, it would not be a successful transfer. But if we're talking about some particular case of the couple of patients, I think that we obviously prefer to have a good quality embryo, because we have a lot of strategies to improve the endometrium, but we don't have any strategy to improve the embryo quality. So if we have not good embryos, the only thing that we can change is to go to the egg donation and to change that to improve that thing. But with endometrium, we have a lot of kind of medications and strategies to improve that part.
Perfect. That was really nice and clear. Thank you. And I'm going to put you on the spot a little bit here, but I probably will ask the others too. If you were to put and I'm speaking to the audience now as well, don't get too excited about the numbers or the percentages that I'm going to ask for. It's just to get a rough idea. If you were to say percentage-wise, on average, not specific patient, how do you rate the embryo as importance compared to the endometrium? In other words, how many times are you going to see an embryo that isn't sufficient quality or chromosomally normal compared to an endometrium that isn't? Because people have to decide where they're spending their money, what they should focus on, what they should prioritize, and it's not always obvious before you start a cycle. So on average, can you give a kind of percentage? Do you know the kind of question I'm asking? Do you know what I mean? Asking how relatively important is the embryo compared to the endometrium for the average patient?
If I'm allowed to start first,
please go ahead.
With this, of the rest of the panel. So, in my belief, I think that as also the other two speakers mentioned, that we should not allow the audience believe that we have a magic bullet to identify which is the correct time for implantation. So we know from studies after pre-implantation genetic testing, even with donor eggs, that the maximum that we can achieve in implantation is around 70%. So in my experience, there are still 30% of patients with obviously at least chromosomically tested embryos that do not implant in almost perfect endometria, or we think that we have prepared them this endometria in the right way. So in my belief, I think that if 70% is the embryo important and 30% is the proper endometrium, and I mean, when I speak about endometrium, I'm not concentrated only in the implantation window, but also in how intact is the uterine cavity, if the uterine cavity has been modified from previous surgeries, etc. So in my belief, I think that 70% is important embryo and 30% is endometrial and also immune factors and other factors that they take place during implantation, endocrinological factors.
Thank you. That's really helpful. And yeah, sorry, I don't think I put the question completely correctly, but that was exactly the sort of answer I was looking for. So do either of the other doctors have a different percentage view, or do you want to make any comments on that? It's okay if you don't. Just giving you the opportunity.
No, we agree with the doctor, because
Halyna, thanks, Susanna. Do you have a different idea, Halyna?
If I can add, there is a guideline of repeated implantation failure, quite recent guideline, and it was written that if we have a genetically tested embryo, good quality embryo, after one unsuccessful embryo transfer, we can thinking about implantation failure, and in this case, we can thinking about some additional investigations. If we had non-genetically tested embryos, the probability of implantation is around 40% because of genetic problem and so on. So in this case, probably after 2 unsuccessful transfers of good quality embryos, we can thinking about additional evaluation.
Okay, thanks. That's really helpful to add in, evidence-based stuff like guidelines. Would you be referring to, is that an ESHRA guideline?
Yeah, it's ASHRAE guideline.
Okay, thank you. Just for the audience's benefit, just to know that's a recent guideline that came out. Okay, that's great. I know there's some questions in the chat, and we are going to get to those. So let's start with one that's very specific to looking at other factors, because I think it was really important what Dr. Papanikolaou said about there's quite a lot of things to look at. We're focusing on receptivity today, but there's still many other things that we need to be looking at to make sure the endometrium's in the right state to accept an embryo. So how big, I think that probably means thick, how thick should the endometrium be? This lady often has 8 millimeters and everyone says that's fine. Dr. Malkhasian, do you want to just talk about, because I've spoken to quite a few patients over the years, and they understandably, once you say a number, it becomes like a threshold. It becomes like if I don't achieve that, it's game over. So do you want to just talk a little bit about that 8 millimeter kind of golden number, and what if it's lower, what if it's higher, and what that means for them, please?
Yes, of course. Yes, for 8 millimeters, it's a perfect thickness of the endometrium. In our clinic, we use the numbers from 7 to 12 of the endometrium thickness normally, that we consider okay for the embryo transfer. But we have a lot of patients that in their cases they never get this endometrium thickness. Include when we use the hormone, the higher doses of hormones and another additional medications for that, they never get to this thickness, and they may have only 5-6 millimeters of endometrium. And since not a lot of time ago, we start to use some new treatment with the platelets, rich plasma, and we saw that even with this kind of these endometriomes, like 6 millimeters, we can do the transfer, and this woman can get pregnant with endometrium too. So it's very important to explain them that sometimes we cannot get this perfect gold standard number, and it can be okay too. Okay.
Okay, thank you. With any of the other, yes, Dr. Evangelos, let me. Oh, sorry, I clicked off. Go ahead, please. We can't hear you. You're on mute.
This is a very crucial question from many patients. What is the proper thickness of endometrium? So there is a huge study, more than 10,000 acceptors. I don't remember if it's coming from Spain or from the United States. It's a huge registry where they have shown in acceptors with egg-donated embryos, okay? So they have shown that above 7 millimeters, the result is the same. The clinical pregnancy rate is excellent. So with 6 millimeters, we have 10% decrease of the pregnancy rate. With 5 millimeters, we have 20% of decrease of the pregnancy rate, and less than 5, then the pregnancy rate becomes extremely low. Still exist cases that become pregnant, but is around 10 to 15%. So it seems from this analysis, it's not a meta-analysis, it's a retrospective study of a huge data, seems that 7 millimeter is an excellent threshold, and so patients, they should not get frustrated if they have 8 or 7 point something, and even with 6 millimeters, we can cancel once the cycle, for example, and if we repeat a new cycle and we see, or we have registry from the previous treatments that this is approximate the maximum thickness of the endometrium, then we should realize that this 6.2, this is the maximum for this particular person, and we should not frustrate her more than this.
Okay, thank you. Dr. Strelko, do you have anything to add to this?
Also, it is important to not have very sick endometrium. because in the same study was written that more than, it seems to me, 13 or 14 millimeters results of implantation also decrease, probably because on bad blood circulation, or I don't know. It was not explained, but it's true that optimal thickness is around 7, 8, 9, and more thick also not good.
Okay, thank you. I'm just trying to, keep a theme going. So this one probably flows quite nicely from the last set of questions and answers we've had. Can we expand it a little bit? What other testing is recommended for several failures? And the endometrium's good, by which I think means 7 or more millimeters, and good embryos tested. And we'll embryos tested meaning that they're chromosomally normal and presumably good quality. And there was a question about good quality, and I just want to say something about that. There's lots of different grading systems. So the ESHRE guideline will probably say exactly what standard was used for good embryo quality, but there's good quality grades for day 3 and there's good quality grades for day 5, day 6. So rather than give a number here, I think it's probably better referring to the actual guideline. So Dr. Malkhasian, can you answer that one about what other things might we look at when we've looked at the endometrium? That seems to be good, or certainly the thickness is good. The embryos have been tested and there's been several failures. So what are all the things we can look at?
One of the first things that we recommend our patients in these cases with the implantation failures is to do the hysteroscopy test, because sometimes we can have any problem in the endometrium that we cannot see in the ultrasound, like a little polyps or like a septum or something like that. So we usually do the diagnosis with the hysteroscopy. It's the method that we have to see the uterus from the inside with a little camera. And it's very easy to do. So in the same time, if we can see that there is any structural problem, we can fix it in the same time. And we use it to sometimes to have a biopsy of the endometrium to see if there is any endometrial chronic infections or something with the different bacteria that they can be in this area that could need some treatment. This would be the first thing that we would recommend. And another thing, it would be to see if there is another kind of systemic disease. We usually make tests with the autoimmune system diseases. It's just a blood test, and to see if we have any another problem that could be fixed with some kind of medication added to the protocol. And another time when we have all these tests, and obviously, as Halyna said before, the endometrium test to see the genetic, the expression of the genes in the implantation window, it could be performed too. And if every test it's okay and we can still don't know what's the reason of these implantation failures, we usually use like an empiric treatment with different medication that we have, just to try to improve the vascularization of this endometrium, like for example heparin, aspirin, and sometimes corticoids, to see if it could help in this stadium of the implantation, because there are a lot of time that we just don't know where is the problem, but because we cannot study, we have no methods to know everything, and there are lots of parts of the implantation moment that we still don't know. So sometimes we use this kind of medication just to try if it helps to have a better result.
Thank you. I think what's really interesting about your answer, and the other doctors have alluded to this as well, is that one thing, there isn't a silver bullet for for problems, but also just focusing on one test or one idea is not always going to solve the problem. So I'm loath to use the word holistic because it kind of has a different meaning, but what you're talking about is making sure you properly examine all the key things to make sure you haven't missed something, right? It's not just about let's do receptivity testing. It's about making sure that you've checked everything and ruled out any other problems. And I think that's really important. So thanks for that. Let's answer a quite specific, but I think it might apply to quite a few people. So let's go to this one. And can I go to Dr. Strelko for this one? How can the endometrial receptivity get better, or what things could we do to improve receptivity and the endometrium in general after endometriosis and or adenomyosis?
Thank you. Very good question. So I would like to add to previous question that probably one of the problem which we should test also sometime is chronic endometritis. And when we have chronic inflammation inside of uterus, it may displace the implantation window. And there are some publications about changing of implantation window after chronic endometritis treatment. And this is part of the answer to this question. If we found nothing, we can try to do some additional tests to this chronic endometritis, and if we found something, we can do specific treatment, and it will for sure improve the probability of implantation. What about endometriosis? It was described some specific immunohistochemistry tests like BCL6, for example. And if the expression is very high, it means that it may decrease also the probability of implantation. So in this case, probably the treatment of endometriosis previously during maybe 6 months also should improve the probability of implantation. What can we do else? Me personally, I prefer to do the cryoembryo transfers in natural cycle because endometrium is growing better, because natural estrogens, there are 3 types of estrogens instead of 1 when we take replacement hormonal therapy, and it improves their receptors connection and it acts better to endometrium. And also when we have natural corpus luteum, it may produce some substances which relax uterus better, and these contractions of endometrium is not so high, so improve the probability of implantation of embryo. So my answer to exclude chronic endometritis, treating it. If we have endometriosis, also to have specific treatment, maybe hysteroscopy, maybe medication, and also to try to do in natural cycle.
Okay, perfect. Thanks. We'll be coming back to the, I'll be going to all of you in turn and asking about indications for receptivity testing and natural versus HRT, but we'll do that at the end. That's like kind of polling type thing. So I just want to make something really clear, because when I was working in industry offering tests to look at endometritis, even our own staff sometimes got confused about endometriosis and endometritis. So just to be clear, they're very different, and you're talking about a different thing. They just have a lot of letters in common. So you mentioned, well, both you and Dr. Malkhasian have mentioned the microbiome in different words, but you've talked about chronic endometritis, you talked about infection, and I just wondered if Dr. Papanikolaou, if you'd like to talk about microbiome testing. I don't know if that's something you're offering, but what your thoughts are on that, not just for chronic endometritis, but for lactobacillus, just for the general microbiome.
Yeah, it's also important to have normal microbiome of endometrium and good concentration of normal lactobacteria. And yeah, time to time we can offer this test. From Ukraine, it is quite difficult to organize the logistic to send these samples to laboratory, so we don't do a lot, but sometime we are doing that, and it's really important to have a normal microbiome of endometrium, and it may also improve the probability of implantation.
Okay, thank you. Evangelos, what's your feeling about this?
Let me offer my notice and my beliefs. Actually, I'm quite skeptical regarding the microbiome concept. And the reason is that, of course, it's not expensive anymore, so we offer it in more and more patients. And my problem is that the majority of the patients, let me say 90% of them, they have, first of all, abnormal lactobacillus concentrations. So almost all the patients are abnormal. So the problem is that even if we give treatment and we try different treatment protocols with antibiotics and local lactobacillus in the vagina, because we cannot offer anymore in EU vivid lactobacillus. So we see and we repeat the microbiome 2 to 3 months later, only a minority of 10-20%, they really improve the concentration of the different microbes. So, and if we proceed, of course, we cannot try again to postpone the embryo transfer another 3 months, giving another medication, etc., and ask the patient to pay a third microbiome. So when we proceed in this, most of these patients are acceptors, oocyte acceptors. So they have finished with their probabilities with their own eggs. So actually they are fighting with a 50% chance. So we see still excellent results after 2 microbiomes still being abnormal. However, I still feel that microbiome should be offered when we fail after PGTA tested embryos. In that scenario, if we transfer a genetically tested embryo, I think we should not let out of the workup the microbiome status of the endometrium, because even if these rare cases of 3%, 5%, as Dr. Elena just mentioned, from chronic endometritis can be identified, and we can decrease a little bit this status of inflammation, and we usually do this by adding corticosteroid afterwards in the treatment, in the new treatment, then we might expect a better implantation for this patient. So definitely there is a point for this exam, but I think that we are still in the early stages of an evolving exam that should be more and more elaborated in the future and become more accurate.
Okay, thank you. Dr. Susanna, is there anything you'd like to add about if you're using the microbiome test, or even if you're not, what your thoughts are about it? Obviously, we do need to differentiate between looking at the bacteria that are associated with chronic endometritis versus looking at other bacteria, including lactobacillus, which are kind of 2 different stories. I mean, they're linked, but they are 2 different stories. So what's your feeling about testing for that, treating it?
Just in my practice, we have a lot of patients that when we do this test, we have a lot of diagnosis of the endometritis. And sometimes we try to treat it with antibiotics, corticoids, and then we repeat. When we repeat the test, the endometrium biopsy, we still have the same results. So I don't know how really important is that, but what we started to do in our clinic is to give all the patients, try to give them, like when we start the IVF treatment, we always use some vitamins for the pregnancy, and we have some complex that they have another pill with the lactobacillus. So we try to, as it's something that will not cause any bad thing, and it doesn't have any important secondary effects.
Sure.
So we prefer to give this kind of treatment to the patients just to cover this part. but we don't do a lot of tests of this kind.
Okay, I'm intrigued when you said, because this is why I wanted to separate or differentiate between chronic endometritis diagnosis, by this molecular method, and non-dominant lactobacillus, which is how I think the companies that offer this test, that's how they refer to it. So you said, you get a lot of, you said a lot of people with positive for chronic endometritis, but do you just mean an abnormal result based on the way the results are reported, or do you mean it's a pathogenic bacteria that needs to be treated with an antibiotic?
Yes, sometimes I think that in most of these cases, by our experience, we have the diagnosis in the pathologic anatomy with some molecular dates, but in the biological analysis of the bacteria, it's almost always it's negative for the infection. So we just treat it like it was an inflammation, not an infection. Okay.
All right. Thanks for that. So let's move on to a different question. This one is definitely, it could get complicated because having been involved with the receptivity test, I know that things have to be done exactly according to the instructions. So we might need to get some clarification on this question, but I'm going to go to this one. And Halyna, can I ask you to answer this one, please? So it's, I guess, an ERA result of 5.5 days receptive. I think that's what that probably means. How can this information be used to plan a transfer with a natural modified cycle with trigger? And my question, I suppose, is if that ERA was done in a HRT cycle, then I don't think those things are comparable, are they? And I don't know what your thoughts are on how you would use that result. But please answer the question however you would like.
Yeah, this is the main question, because if ERA test was done with artificial cycle, you should do the transfer, normal transfer, with the same protocol of preparation. Otherwise, this test is not relevant. So if it was done in natural cycle, so necessary to repeat the same. I mean, if natural cycle and 5.5 days, it means that HCG and plus 7.5 days.
Okay, perfect. That's what I was hoping you would say. Basically, to highlight the difference between a natural cycle and an artificial cycle, and how they can't currently, at least currently, the way the tests have been evolved and developed, they're not reproducible when they're being done differently. That's the point, right? So thanks for that. Let's move on from that one, and then let's go back to the microbiome again, because I see one here. I think this question, Susanna, could you answer this one just from what you currently do? I think this question means, is there a different alternative to probiotics, or would you be recommending vaginal probiotics to increase lactobacillus? Because obviously there are other ways of getting probiotics, yogurt being one of them, and oral being oral pills being another.
Here in Spain, we in this time we only have the oral pills with the probiotics, but we hope that the vaginal, they will come back soon. But for now, we only have in our pharmacies the oral ones, and that's what we use normally. And as I told you before, we usually give our patients a complex of vitamins that includes the lactobacillus too in another pill. So it's very easy to them to do the treatment, and they can start them since when we have the result and when we have the protocol of treatment, they already are starting to take this pill to have an effect when we get to the embryo transfer.
Thank you. Evangelos, do you have anything to say about, ideally, I mean, I understand, Susanna, if you can't get hold of vaginal probiotics, then obviously you can't use them. But would there be a preference for using vaginal versus oral?
Look, Alan, in the beginning, it's the same situation, first of all, like in Greece, like in Spain, for the rest European countries. Now we have the availability of, we used to have vaginal, and the initial rationale was towards to give them vaginal as the progesterone, but apparently also the oral preparations are working very well, because the gastroenterologists all these years, they used to give oral probiotics. So it seems that soon maybe it might need a little bit more time. I don't know exactly, might need 2 months instead of 2 or 3 weeks to get the actual to differentiate the flora in the vagina first and then into the uterus. But it seems that the new preparations are really working, the oral, I mean.
Okay. Yeah, I mean, I'm ignorant, so I'm only asking the sort of scientific question. I'm not sure I understand the mechanism of, getting all the way to the vagina through the oral route. It's conceivable, and anything to do with the gut, and the gut's linked to many other systems now, the brain and so on. I can sort of get that. It's not clear to me how oral gets to the vagina and therefore the endometrium smoothly, but and easily. But that's for another day.
The secretions, the vagina is the epithelium, the vaginal epithelium secretes all different substances that make the cultivation of lactobacillus more and more prominent in the vagina. This is the way of action.
Okay, that's the mechanism. Okay, thank you. So then we got a very specific question here. Halyna, could you answer this one? So it's a particular compound, intravenous. I'm guessing that's what that is, to improve implantation. Is that something you're familiar with, or if you're not, if any of the doctors are familiar with that? I'm not sure if sometimes the spellings aren't accurate, but.
Sincerely speaking, I don't use a lot this kind of treatment, but there are a lot of articles which say that it may be helpful. I try a couple of times, but I have no big experience. Maybe other doctors has more experience in this field. From my side, I would add a couple of words about microbiome and about what we discuss about lactobacteria. It seems that it is important also to mention that for women in menopause, for example, it is not only necessary to give probiotic, but also maybe for some months before the transfer, restore the hormonal level. I mean, give some replacement hormonal therapy, good level of estrogens, because otherwise lactobacteria will not have, soul to growing. I mean, without normal hormonal level, will not be able to restore normal microbiome. And as for me, it is important.
Okay, and just on that point, because that's taken us in a slightly different direction, which is really interesting. When you said menopausal women, do you mean in that sense women who are using donated eggs?
Yeah. Women who would like to do egg donation treatment come with a very low hormonal level, menopause, and in this case, as for me, preparation should be done couple of months before with some replacement hormonal therapy to restore hormonal level, and microbiome will be better in this case.
Okay, that's really interesting. Thank you for that, because I'm not saying people think egg donation is like miracle cure and 100% success rate, but we know that around the world egg donation has extremely high success rate because the eggs are usually from much younger women and therefore more viable and so on. So it's good to know that there's still a lot of focus on preparing the recipient to make sure the endometrium is in the best possible state to receive that high quality embryo from a young egg. Maybe I think nobody else has put their hand up to answer that specific question about particular treatments, but we were going to do a whole session on PRP, and we're no longer going to do that. But does anyone else want to say anything? Susanna, I think you already mentioned it, but does anyone else want to say anything about PRP if they're using that for implantation failure at all, or other reasons?
So
Let's go ahead with Evangelos and then we'll go round. Thank you.
So also it's an interesting story, the PRP, not for ovarian rejuvenation, but for a poor endometrium, to make it clear, okay?
Yep.
So I just want to confirm my personal experience. I started doing PRP in a lady with multiple implantation failures abroad, a British lady that she came to us after multiple implantation failures, and with thin endometrium, less than 6, 5.1, 5.2, and she became pregnant, and only after PRP, so it was our last resort for her. And unfortunately, that lady, she had to terminate the pregnancy at 24 weeks because of very premature preeclampsia. So unfortunately, she never got a baby after this successful egg donation after PRP. So after that lady, I started using PRP more often in thin endometrium, and not for recurrent implantation failure, for thin endometrium. And I can say that it's not working always, but sometimes it's not that increasing the thickness of endometrium, because it's fake, the increase of thickness, because you just infuse something in the uterus, so always something remains afterwards, and so you can see a fake increase of thickness afterwards. But it seems that maybe all these growth factors, and there are so many ways of preparation of PRP, so actually you don't know which is the best way of preparation of PRP. So anyhow, it seems that might add somehow in some patients, but it's really still experimental, and people should not put their hope on this method.
Okay, thank you. Would Halyna or Susanna want to add anything about PRP? Any experience or opinion?
No, I agree with the doctor, because we have no so much studies about that, so we need to wait a little bit to see if it's really so good. But in our clinic, we use it a lot in both cases, to the implantation failures and when we cannot achieve the enough thickness of the endometrium. And in both cases, we have a really good results, but we still have to study to say that it's really so good.
Okay, thank you. Halyna, do you want to say anything?
As for me, I have also experience to use PRP, but I agree that there are different methods to preparing, and I have no so huge, success rate after PRP. For some women, it's improved results, but maybe not so many, maybe 20%, something like that. Not for all.
Okay. Yeah.
As for me.
I think that
own experience.
Yeah, no, that's a good summary from everybody. Is it's still, I don't want to use the word experimental necessarily, but it's early days, right? It's early days to be able to give really good information about it. So let's move on to another one. And I'm going to ask you, Evangelos, to answer this one first. Does sugar consumption affect implantation?
It's the first time that someone is asking this question. I can say that drinking zero Coke doesn't affect the implantation window. So if this answers the question, I don't know really. I don't know if extreme consumption of sugar triggering increased production of insulin might affect the implantation. I never had this question, or I never read any paper on this.
Well, how about we expand it a little bit to say, if a patient came to you and said, I consume a lot of sugar, what would you say? Why would you tell them to try and reduce that? Because I'm pretty sure you would say, I think you should reduce that, but you'd have to give them a reason. And it could be just general health benefits, but would there be a reproductive medicine related answer?
Alan, if someone tells you that this is normally, it's a PCO lady with increased BMI, and we know that the decrease of BMI, particular in these patients, that they have already, not all of them, but the real PCO ladies, the PCO syndrome, let's say, they have insulin resistance, and by decreasing sugar consumption, you alter and ameliorate this physiological metabolic syndrome that some of these patients might have. So in this particular population of PCO ladies, definitely the decrease of sugar consumption enhance the metabolic syndrome that they have. So this is the mechanism.
Okay, thank you.
That's why we propose.
Sure. Would you, other doctors, would you like to say anything about, very briefly, what your advice about excess sugar consumption is? Probably is reduce it, but the reasons you give, or are they exactly the same? Go ahead, Susanna.
I don't know what can I add to the answer of my colleague.
Okay.
But I think that not only the sugar is important. Nowadays, we know that for everything, not only for the implantation, it's very important to have a good diet, obviously. So I think that one of the things that I would say to my patient is to have a consultation with the
nutritionist. Yeah.
Nutrition, yes, to do the right diet, because sometimes in cases of polycystic syndrome or endometriosis, it could help a lot.
Okay, perfect. Do you have anything to add, Halyna, to that?
It is raised the question of diabetes, probably, because if your patient has high blood sugar, because on consumption or because on, I don't know, because on diabetes, it may, of course, influence implantation.
Okay.
This is the main question as for me. So necessary to do some additional tests to see if she has type 2 diabetes or she's obese, because obesity also decreases the probability of implantation around 30% less.
Perfect. So, I mean, as a coach, I guess I would say, and I'm sure you do it as doctors as well, you hear a question, it's very specific, but you dig a little bit deeper and there's always a bit more underneath, right? If someone says, does sugar affect something? Maybe they mean, does my BMI affect it? Does my diet affect it? It can be a deeper question, right? So thank you for that. And sticking with you, Halyna, can you deal with this one, please? So, and this is not something I'm particularly familiar with, so this is good for you to answer this. Introducing or reintroducing HCG into the uterine cavity prior to embryo transfer with the purpose of increasing receptivity.
Yes, I know this method. It is approximately, first publication was maybe 4 or 5 years ago, and it was proposed to put 500 units of HCG in uterus 30 minutes before the embryo transfer. And yes, we have done that several times, and in some cases it may improve situation with implantation. We have no so many cases to give the good statistic, but for some patient we are doing that. It is easy, and
okay.
I found it may be helpful.
Okay, so I think this one possibly goes into the same category as PRP where, you know, it's worked for some people, but we don't have a lot of evidence. So it's just one of those things to try. There seems to be some rationale for doing it, but we don't have enough evidence to say it should be part of standard treatment. Is that fair?
About rationale, it may modify probably receptors and improve the endometrial, how to say, maturity, but difficult to say what exactly the mechanism, how it is working. But it's true that after 2-3 unsuccessful transfer, we are using that and it is working.
Okay. Perfect.
And it was the first publication and presentation during ESHRE 4 or 5 years ago, and they give also very good results without specific explanation why it may working.
Okay, thank you. Does anyone else have any experience of using that, successful or otherwise? Evangelos?
I think that these are crazy things to experiment with that. They have done randomized studies years ago with giving ACG, not intrauterine, of course, but intramuscularly before the embryo transfer with no impact on the implantation. And definitely there is a rationale because ACG is mimicking LH activity. So LH is the denominator of the implantation phase. LH is a very important hormone during implantation window because it enhances the expression of many receptors, but giving maybe this is a very low dose, but we should be very careful because if you give particularly in endometrium ACG, you might downregulate the expression of some molecules. You can achieve the opposite result. And it used to be a study that was interrupted 10 years ago that they were giving extreme doses of ACG at the day of the transfer in acceptors, and after a certain level of ACG, the pregnancy rates were very, very low, so they had to stop this randomized study. Actually, this was from a center in Greece. It was a randomized study published 15 years ago, so they had to quit the study prematurely because of very poor outcome. Not in intrauterine, of course, but we should be very, very careful.
Okay, thank you.
Yeah, I agree with you, but intrauterine and intramuscular, it may act by different way. That's why it's maybe different.
Definitely.
Yeah, I mean, you know, if I up level a lot of the things we're hearing tonight, it's very easy, I guess, particularly as a patient, but I think even as a professional who, you know, hears lots of new things, buzzwords and so on, to assume that, you know, when you hear the same word like ACG, it's being used the same way. And I think from my laboratory background is things can make a big difference by doing them slightly differently or using them in a different way or not following the standard operating procedure, whatever it is. So I think we do need to compare apples and apples with all of these things to be absolutely sure we're delivering the best quality and service.
And Alan, we should be careful because not performing randomized studies or quasi-randomized studies, just a presentation in ESHRE that I don't speak about this particular study, but you know, 90% of the presentations in ESHRE and SRM, they never get a publication. So this signifies a lot of things, that if you cannot have a publication when you have an abstract accepted in ESHRE or in SRM, it means a lot of things. So we should be careful until we see real huge randomized studies, for example, in egg donation patients or after pre-implantation genetic diagnosis, okay, instead of small pilot studies. Anyhow, I'm very cautious because we have also the experience of failure of embryo glue in the past. When I I was young and I went to Brussels 20 years ago, embryo glue. Everybody was thinking that it's a real big thing, and there were many studies. But when we came into randomization, we found that there is no positive impact of embryo glue on the outcome.
I just want to remark on that, not because I'm recommending or endorsing embryo glue at all, but interestingly, I mean, I did a small study many years ago with the early version of embryo glue, and I didn't see a difference either. You can always criticize pretty much every study, and maybe mine wasn't well designed. But interestingly, embryo glue is one of the few things that's used in IVF, and even the ESHRA guidelines on add-ons that came out recently pretty much confirms this. It's one of the few things that actually has quite a lot of evidence supporting its use. So go figure. Now, I'm not disagreeing with you. I'm just saying if you look for multiple studies, it's one of the few things that actually has large numbers, multiple studies, most of which, not all of which, show an improvement. So
because, Alan, it was industry driven also, the studies. PRP studies to be randomized, there is no interest from the big companies to do any randomization, but embryo glue was industry driven, a lot of the studies. So they supported these studies in that era. If I remember very well.
Yeah, I mean,
I'm thinking.
I don't want to get into a debate about the value of different types of studies, but we can't on the one side say we want studies, and then when we have studies we say, well, they're not the right kind of studies. Nothing's perfect, right? I mean, we know that. Anyway, let's move on. I've got a question for Susanna now, and it will open up the concept of looking at the embryo again. So it's quite a long one, but I think it's really quite a simple question. It's very specific. It's somebody saying they've had 2 failed embryo transfers, they're 41, now using a donor embryo from a 24-year-old. Should the embryo be PGT-A tested? But if we up-level this question, just say, what's your thoughts about testing embryos from young donors or from women who have their own eggs and they're young? What do you think about that?
Of course, I think that PGT-A test is the best thing that we have. So we would recommend it to all the patients, even if they use the egg donation from the very young girls, because it's very important to know the genetic part. And we know that in the young women, the rates are not so high of the genetic disease. So obviously we cannot do them, but they are totally recommended in all the cases, I think. And now we are practicing another test too. It's like the PGT-A, but non-invasive one. So in these cases, if the patients are interested to have the best results in less time, and to have to assegurate that the embryo is healthy, we usually recommend this kind of test that will tell us about the percentage of the healthy embryos, and it will tell us with what embryo we have to start the transfer. Because normally when we use the egg donation, we have not one embryo, we have more than one. So to know with which one we would start to have a successful result, this kind of tests are very helpful. But obviously the couple will decide if they want to do them or not. It depends in every case, because we have to think about the economic part too, which is important too. So we cannot do this test to all of the patients, so they can decide, but they are totally recommended in every case.
So you mentioned the non-invasive test. I'm familiar with that. What's the I'll come to you in a second, Halyna, don't worry. What's the benefit of doing a non-invasive test for the sake of the audience? And does it give the same results or exactly the same results as an invasive test?
No, it's not exactly the same. In our practice, we usually recommend the invasive one when we want to be sure 100% that the embryo is healthy. So we recommend it to women that are 39 or more years old, because in these cases it's very important. And when we have couples that are younger, and when we are waiting to have more than one embryo, we usually recommend a non-invasive test, because it helps us, it gives us an information about them if it has genetic problems, but it's not a diagnosis. That's why it's not the same like an PGT normal test, the invasive one. Here we have only the rates, the possibilities of them of the disease, but it's very useful to see which one which embryo has more possibility to implant. So it's very helpful for us to know which one we will start to do the implantation. So in these cases, I think that's very useful. And as I told before, the economic part, maybe in these cases it's not so expensive, so it could be an alternative. And we don't touch the embryo, so
I was hoping you were going to mention the fact you don't have to biopsy the embryo. Yeah, that's a big benefit for a patient, right? You don't have to biopsy the embryo, even though we think that that's safe because of years of doing it. I think everyone would agree they'd rather you didn't have to biopsy the embryo. Okay, and the word I'm going to use, you've described it really nicely for non-invasive. Prioritization is probably the best word to use, isn't it? Rather than saying I'll keep this one, won't keep this one, it's I'll transfer this one first, and I'll transfer that one second or third or fourth or whatever. Yeah. Okay. Thank you, Halyna. Please. I'm interested to see if you have a different view of what you would do with a 24-year-old donor.
Yeah, before we was raised to recommend doing PGT-A to most of our patients, but last time, especially for this category of patient, we don't recommend to do PGT-A because, first of all, the probability of genetic problem is not high. Second, because on discordance, I mean that if you do biopsy several times, you may receive different results because you can have some part in your trophectoderm with abnormal cells, but most of your trophectoderm will be normal. And also maybe discordance between trophectoderm and embryo. And there are also publications saying that before 38 years old, PGT-A does not really recommend it from medical point of view, only in case on repeated implantation failure or maybe some problem before. In case on non-invasive test, it may be a good idea to do for most of patients because as minimum there is no biopsy and no damage, even little damage to embryo. So as for me, for egg donation programs with young donor, I'm rather not for doing PGT-A.
Thank you. That's really interesting to have a slightly different take on it. Evangelos, do you have which side of the fence do you come down on for a young donor for PGT-A?
So first of all, it's not allowed in Greece to do PGT-A in egg donation.
Okay.
You should, I do not agree with this law, of course, but you should ask for special permission that the very rare give the permission. And I disagree with this law I'm saying, but on the other hand, once we do, we see that 30% or 40% of the embryos are euploid, with all the drawbacks that Helena just mentioned about the trophectoderm biopsy. So actually, in this particular patient that is asking this question, that at the age of 41, we don't know if she means to failed with her own eggs or with a donor eggs. We don't know this. I think that I strongly suggest PGT-A with donor eggs only when they have one full donation with more than 3 blastocysts failed in our center or from another center. In that particular case, is that a lady, after many implantation failures with her own eggs, and again failure with donated eggs, then I think that with a new donor, we might look into the chromosomal constitution of these embryos, because we might identify a paternal factor, especially with borderline oligostenospermia. So we might decide to change the sperm in another donation cycle. So for this particular patient, I would suggest non-invasive PGTA and not really invasive PGTA.
Thank you. That's really helpful, and thank you for introducing that little extra component that we hadn't really considered, at least in our discussion so far. That rare but important male component. You know, I think tests where they have looked at the parental origin of the abnormality, you know, it's 90% plus 90 to 95% maternal, female. But if you can pick up those paternal contributions, then that's really important. So that would be one situation where that might pop up more often. Did you have something to add, Halyna?
Yes, we are doing quite often the genetic test of sperm. Not often, but in some case with teratozoospermia, for example, and really rarely receive abnormal genetic of sperm, because genetically abnormal sperm cells start apoptosis and by themselves disappearing. So it's rare to receive abnormal result with genetic of sperm. But it's true that with teratozoospermia we have less blastocysts and more often genetically abnormal embryos. So it may be some of indication to do PGTA in egg donation. Or second point, that if, for example, we are thinking to do endometrial receptivity test, we should be sure that we have genetically normal embryos. Otherwise, it is okay. We will not understand which one is guilty.
Understood. Yeah, if you have two problems and you only look at one, you haven't fixed the problem unless you found a problem. Yeah. And even then, you might fix one problem and then still have another. Yeah, no, that's a really good point. While I've got you, then I'll give you this question because I think it's really important to differentiate between the old term endometrial scratching and removing a biopsy that you actually test and get information. So do you want to? And I'm really interested in what you all think about this. So we'll start with Halyna. What do you think about scratching as a way of potentially improving implantation? I think that's what that question means. And please, highlight that it's not the same as doing a test. It isn't, is it? It's just scratching or taking a biopsy with doing nothing with it.
Yeah, this method was described quite maybe 10 or 15 years ago. And at the beginning we have done a lot, but me personally I don't do now and don't found a lot of benefits of this method.
Okay.
So
thank you. That's yeah, no, we'll leave it there because we're running out of time and I want to get through everyone. So you would be more likely to take a biopsy and test, right?
Yeah. Me personally, I prefer to do tests for implantation window, for microbiome, for endometritis. We are doing quite a lot endometritis test, and for repeated implantation failure, we found in quite often some problems with inflammations. So I'm not very for this kind of treatment. So
okay, perfect. Thank you, Evangelos. What do you do scratching anymore?
Listen, the old people scratching has been proven that it doesn't work, the PIPEL. But we have published recently a meta-analysis even that it seems, it shows that, and also we have published a lot that during hysteroscopy, when you do hysteroscopically fundus incision, it seems, according to our studies and also to other, and we have published a meta-analysis recently, that we have an increase in the implantation after incision of the endometrial fundus and making a real inflammation and healing process in the fundus of the uterus. So the old way of scratching has been proved that it doesn't work, and we need more studies in hysteroscopical scratching of the fundus of the uterus.
Okay, thank you. Susanna, do you have anything to add to the scratching story?
No, not really, but in our clinic we do perform that. But I think that the reason is because it's a very simple procedure that we can do to all the patients, and it's very easy to perform. So when we have the implant failure, and sometimes we recommend that because we know that it can increase the vascularization for the next cycle and all these things. But really, I agree with my colleague that when you read the studies, there is not. And sometimes they say that it's helpful in these cases, but in another one, there is no clear evidence that it could help. So
okay. So I presume from what you've said, thank you, that's a really nice answer, that it's inexpensive, easy to do, and you're confident it doesn't harm the patient, and that's why you think it's okay to do even if the evidence isn't compelling. Is that fair?
Right. Thank you.
I just wanted to, make it clear to patients what you're saying, because there'll be a lot of people listening tonight who are sort of hearing you all say quite honestly and transparently, oh, there's not a huge amount of evidence for this, there's not, but then you'll say, but we do it. And so I'm just trying to bridge that gap between there isn't sufficient evidence, but sometimes we do it anyway. You see what I mean? Just to help with that. While I've got you, Susanna, because this is very linked to what you answered earlier, can you answer this question, please? About, and make it like, nice and brief, and you've got a patient in front of you and they just say to you, without any test being done, how can I improve my lining and receptivity by supplements? Before I even come and see you and, start having more investigations, what can they do?
I would say, I've already said that, I will repeat, that I would recommend them to take an appointment with a nutrition, to take a good diet. It depends of if there is some concomitant pathology too, of course. And another thing would be the vitamins and the lactobacillus treatment. I think that that's the only thing that I could recommend. And obviously, if they take some nocives, like toxic elements like smoking or something like this, obviously they have to stop it because it's very important too.
Okay, thank you. Yeah, you did say it earlier. I just wanted to kind of, I thought it was worth repeating. Halyna, do you have anything to add or different from that?
There are some supplements with L-arginine, which can relax little vessels. Of course, it will not act very actively, but in some cases it may be helpful, and it's popular.
Okay.
I wouldn't like to take something like that, and it may really improve a little bit endometrium in some cases because improve blood circulation.
Okay, and Evangelos, anything specific that's different from what you've heard already?
Nothing that I'm aware of.
Okay, no problem. Right, we're getting to the end of our session. It's been really good. There's been some great questions. And I've just got a few things to a few questions to wrap things up, because I think we're pretty much out of all the questions in the chat that are relevant. So you've all said you're offering some sort of test, or for some patients. So I'm going to ask you, there's two components to this question. So the first question is, what's your indication for using the test? So describe this, if it's everyone, that's fine. Susanna said earlier, PGTA pretty much offer it to everybody. So this is endometrial testing of the receptivity plus or minus microbiome. If you can say who you would offer it to and why, and then the second part to the question is, does it matter which test you use, or are they all the same? So first one, who would you offer it to and why?
I think if we have to rank the test, PGTA is the best that is available for all of us, for doctors, for physicians and patients. So regarding the endometrial receptivity test and the microbiome maybe should be offered when we have our own eggs in patients with really repeated implantation failure, not after 1 or 2 blastocysts from a single cycle, but at least 5 or 6 blastocysts from a single IVF stimulation, or from at least 4 blastocysts after 2 different stimulations. And definitely after one failed egg donation, I think that we should offer microbiome or ERA test.
Okay, thank you. Susanna?
I think that obviously we cannot do all the tests for everyone, and we have to prioritize them, and it will depend on our clinical suspicions that what could be a problem in every case. And as my colleague said before in the beginning of this conversation, that we have to see we have to look the percentage of the problems, because in more than 70-100%, the problem is the embryo. So the first thing that we should study and we should exclude is the embryo problems with the PGTA test. And then when we still have the implantation problems, start to do all these tests that we said before, with the ERA test, hysteroscopy, and another test that we have.
Okay, thank you. So that's nice and clear, actually. You're pretty much saying, and let's put aside, I'm not saying it's not important, money and desire and fear of doing an invasive thing like a biopsy, but what I'm hearing is you're saying if you haven't got a normal embryo, you shouldn't start looking at the endometrium. You need a normal embryo first. Is that fair? Yeah. Okay. Good. Halyna.
Yeah, as for me, to have a normal embryo, it is the main things, because without we will not have implantation. So if I have women less than 37, 38 years old and with very good embryo quality, okay, I don't do PGTA, I don't recommend as routine PGTA, but I propose that it may be helpful to understand if your embryo are really good. And sometimes it's true that we can have surprise. Young women, good embryo quality, and mostly all are abnormal. Sometimes it happened. So if we don't thinking about money, PGTA, it's not bad, especially if we can do by a non-invasive way. Then if we have done 2-3 embryo transfer with good endometrium thickness, with good embryo quality, with good technique, with good hormonal level, and sometimes also I prefer to do different preparation protocols. For example, one was with natural cycle and another one with artificial cycle, because sometimes changing protocol may be helpful also. So if after these trials nothing happened, I will propose to do some additional tests on implantation window and on microbiome also. Something like that.
Okay, thank you. Yeah, that's really helpful. I take your point about, not everyone can afford to do PGTA, and sometimes, at least in your practice and in other practices, a young woman with a good quality embryo, it's not automatic to offer PGT-A. I get that, but it's sort of almost like a proxy for doing it. It's, you know, it's a young patient. You expect to have a high percentage of normal embryos. So then you might, if you have enough failures, then you might go to endometrial testing. Well, that's been really fascinating. Thank you. There's been quite a lot of consensus from our doctors, but there's also been some, you know, some interesting differences in the way they provide care. I think we're pretty much out of time. It only goes to thank our doctors, thank My IVF Answers and Ask Your Doctor specifically for putting the event on, and thank you to all of our participants. You've had some great questions, and I really hope that's been useful for you. And hope to see you again soon. I think we've got another one on the 5th of March about actually about PGT-A. So if you're interested in that, please come along to that. And I'm doing one for My IVF Answers, not Ask Your Doctor. I'm doing a webinar for about coaching on the 29th. So keep your eyes peeled for that. Thanks very much. I'm going to close off the meeting now. Goodbye.
Right.
Bye.
Bye, everyone.
Thank you.